my name is Sarah Smith. I work for the Office of Community Partnerships and Planning at Grinnell College. I have the honor of partnering with Bucket Course committee members to bring you the Bucket Courses each week. So great to see everyone. Welcome to this a spring, feels more like spring, course. Just a few things, as you probably are noting, I have turned on subtitles for PowerPoint, but those in the front row, be careful what you say because it's picking up everything. So I'll try to turn those off as we take a break so it doesn't pick up everything. But anyway, we'll try those, and hopefully that will help. Although we have microphones, sometimes for me it's easier to read subtitles from time to time as well. So just a few reminders. I didn't print this out today, so hopefully I remember everything. Please make sure you silence your phones. Please make sure you turn on your T-coils. And there's one more thing, but I can't. We'll have questions. This time we're going to have questions actually throughout the presentation. So if you have a question, please raise your hand. I'll come around with the microphone. David-Paul has asked if we could do it that style today, which is great. And then we'll still take a break and then end a little before or around 11:30 today. If you can stay and help put away chairs, we would greatly appreciate it. But if it's that's something that you cannot do, that's totally fine as well. But we would appreciate the help. So today, very excited to have David-Paul Cavazos from UnityPoint Health here today to present about the hospital. I have to say, David, as I was thinking about the spring bucket courses, I remember that I will tell you, full disclosure, I am on the board of trustees for UnityPoint Health. And I remember when we were interviewing you, one of the things that I really, really was excited about for you to come here and be our rural president here at the hospital was you enjoyed talking with people.
I do.
You enjoyed having coffee with people. You wanted to be in the community and to hear from people and to share all the amazing stuff that's happening at UnityPoint Health. So I thought, what better way than to invite you to this event with all these wonderful people. And so I'm so excited to welcome you here today to learn more about you and the hospital, what's going on. Without further ado, let's welcome David-Paul Cavazos.
So thank you so much, everybody, for coming out today to this event to listen to me talk about the hospital and kind of give a small introduction on myself. My name is David-Paul Cavazos. I have been in healthcare for 28 years now. And if I forget to move the slide forward, please do just remind me. Also, as Sarah said, please don't hesitate to ask a question. If you see something on a slide or if I say something that makes you curious about something, don't hesitate to just raise your hand and we'll take questions as we go. I really like to encourage that because I want people to learn more about healthcare. I think the healthcare industry is very complex, and so I think a lot of people simply don't know how it works, and there's a lot of moving parts to it. So I want people to know about their hospital, all of the great things that we do, just things like that, yeah. Any questions so far? No? All right. And no question is off the table. If you want to know something about me, please don't hesitate to ask. My favorite food is spaghetti. So yes, I have both a Bachelor of Arts. I have a Master's of Business Administration. I am currently the rural president for Grinnell Regional Medical Center. This is my 5th hospital I've been with in a leadership position over where I was CEO of the previous 4. So I've been around in healthcare for a little bit now. So, rural advocate, we love to be involved in the community. I really do try and get involved with things. I want the hospital to have a stronger presence in the community. So boards, committees, things like that. I think we as Grinnell Regional Medical Center are a regional community hospital, and we serve a very large region. We service Grinnell, but we also service the surrounding counties and region. A lot of the stats that we give you will be coming off of local Poweshiek County, but we do serve a greater region than that. So let's talk about some of these numbers here. So the economic impact to Poweshiek County, right there in the middle, you'll see $63 million in total wages. In Poweshiek County, 11.8% of wages come from the hospital. $112.5 million in total expenditures. Hospital expenditures account for 9.2% of Poweshiek County gross domestic product. $667 6.1 total jobs in Poweshiek County. 6.9 of jobs come from hospitals. 2.1 million community benefits. 4.8 thousand encounters provided through community service programs. So I'm also going to talk about the hospital in depth a little bit more. The hospital is a incredibly, for one, we're a non-for-profit. UnityPoint is a non-for-profit health system. But business-wise, what does that look like? Every month it takes $5.5 million to turn the wheel at the hospital. To keep the lights on, to get everybody paid, to process through everything. That's $65 million a year that we are annually. So we're a pretty large organization. Any questions about any of the statistics I've said so far? So about UnityPoint Health Grinnell. Grinnell Regional Medical Center, we're a non-for-profit. We serve 47,000 residents in a 6-county radius of rural central Iowa. I would even expand that to 8 counties now. Our main drivers at the hospital, the main core services that we have lots of services, but our main one is bariatric surgery combined with obstetric surgery, so delivering babies, OBGYN services, orthopedic surgery, and primary care services. I will tell you, just recently, if any of you were listening to the news this past fall, Newton Medical Center shut down in October. They officially shut down their labor and delivery program. They decided no longer to recruit any more obstetrics providers. That was a big blow to the community and the surrounding area. That meant an enormous amount of growth for us in our labor and delivery department. So we've put a lot of focus on obstetrics and labor and delivery, and we've already seen an increase from Newton shutting down their obstetric services. For the month of January, our OB deliveries doubled from what they were in 24. And I'm rounding down, they're actually slightly more than doubled. So that's an incredible thing. That's what I refer to when I say that we service a larger and wider and greater area than just Poweshiek County. It's a good thing for us. What does that mean in terms of our plans and things that we're doing? So it's probably been very much publicized that we have a renovation to our labor and delivery department. We also are renovating our obstetrics clinic as well. Now that renovation, there'll be some more slides coming up about it, but we're putting a lot of money and effort into those labor and delivery services where, unfortunately, a lot of other rural communities and rural hospitals are pulling their efforts out of labor and delivery. It's a very costly service to maintain, and right now, as we currently sit, we are the only hospital on I-80 left that delivers babies. So between Des Moines and Iowa City, if you're a young lady and you're having a baby, it's us. And so we feel that it's very important to pour finances and revenue and funding into those services so that we can renovate our department and just keep our services strong. Any questions around that? Yes. Yes, so he had a very good question. He asked, how does Grinnell Regional Medical Center deal with the viability of OB? Because it is, so another hospital that shut down, although they're out of our area, out of our region, is Muscatine. Muscatine shut down as well, roughly about the same time that Newton did. They came out with an announcement as well. So how do we overcome that? In order for an OB program to remain strong and viable, the hospital has to have a strong surgery program. And here's the connection. So in order to deliver babies, you have to keep a surgery staff on site 24/7 so that you can deliver those 11 o'clock, 1 in the morning babies and do C-sections. So you always have to have a surgery department on call, ready to go. And because of our bariatric services, because of our general surgery services, we have 3 general surgeons. 2 of them do bariatrics. We are a bariatric center of excellence. Because of our orthopedics program, we do orthopedics in our surgery department. We do a lot of joints, and I'd like to see that expanded. Hopefully by the end of the year, I'd like to see us start doing spines and total hips as well, because that will also strengthen our surgery department. As well as we do have a lot of really good, strong OB volume, and more is coming to us. So all of that keeps our general surgery department active. Financially, it keeps the general surgery department alive, so that way they can then keep the OB program alive. One feeds off the other. That's what the big miss is. If you have a small rural community hospital and you hear that they're shutting down their OB department, it's because they didn't have enough general surgery cases to then keep alive their OB department. That's the big kicker. Yes.
Under primary care services, you have specialty.
Yes, we sure do. Yep.
I'll let go for it. That's okay.
Specialty services. What does that? What kind of specialty services would that entail?
So we actually have quite a few specialty services. The question was, under primary care, what are our specialty services that we have? So we have a lot. We have ENT services. That's another line of service that also adds to our general surgery department. We do ENT surgeries. We have urology. We have a cardiology clinic. We also have oncology services. All of those. We also have pain management. Those are other services that combine, and those are, the pain management department is another line of service that adds to our general surgery volume. All of those things help to keep our general surgery volume full, but those are just some of them. Yes?
I suspect I'm backing you up to labor and delivery again. I suspect there's some challenges in staffing with an OB department in a rural hospital. How do you respond to that?
100%. That's a great question. That question was, how do we face the challenges that we see in staffing the labor and delivery department? So I'm going to take a step back and go on a little history lesson here. COVID was very, very hard on healthcare. One of the biggest problems that we saw come out of COVID was that we lost a lot of experienced people. A lot of experienced employees just said, I'm washing my hands of it. I'm going to retire. And that was a big hit to healthcare. So most specialty skilled service lines in healthcare start out at a community college level. Let's talk about nursing, right? Nursing, you can go to a community college and get your 2-year RN degree. So if you were a high school student during COVID, you probably didn't want to go into a healthcare career. So then 2 years down the road, when you would have been normally graduating and as a student you would have been entering the workforce, we had a big gap. There was an empty spot there. And we haven't still recovered from that. We need more nurses than ever. We still need nurses. Now, we as Grinnell are close to being full. I think we have only about 3 or 4 positions open for full-time nurses. So we're right at the line. We're doing very well ourselves. Now let's talk about doctors. Kind of the same thing, right? Medical school residency. If you were a high school student or thinking about healthcare during that kind of time of COVID, the media was pretty rough on us, and you probably didn't want to pursue a career. So take that a step further. Let's talk about obstetrics. So the universities, they keep the reins very tight on obstetrics residencies, and so they only turn out about 6 students a year of residents for the whole state of Iowa. So 2 of those probably go on to specialize. That means 4 that we all fight over, right? And usually they go to whoever has the deepest pockets. So we are constantly always in a shortage and a need for more doctors who deliver babies. And how do we as Grinnell face that? So one of our things, honestly, UnityPoint is an enormous help in this way, and that is the support of recruitment. When Newton Medical Center decided to close their labor and delivery program, what happened there? I received a call from the administrator for Newton Clinic. They are a separate doctors group, and they were responsible for recruiting the obstetrics doctors, but it's very costly. It takes a lot of time. We have an OBGYN position open that we've had open for over a year now. They're expensive. It's expensive to recruit, to use agencies. A lot of money is spent, and they just simply said, we can't do it anymore. We're not going to recruit any further. And Newton Medical Center, as the hospital, said, well, then I guess we don't have a labor and delivery program. And by the end of the month, they were closed. It was a quick and short conversation. Thankfully, we're taking a different approach. We have the resources. We're going to continue to recruit. We're looking at this from a number of different models. We're also really connecting with the obstetrics doctors in Des Moines, and many of them have come out here, the UnityPoint doctors, to help cover with call and over the weekends and things like that, to give a little bit of pressure relief to our doctors. So we work very well with the UnityPoint doctors in Des Moines in that regard. So that's how we overcome those challenges. Yeah. Yes?
At one point, there were no doctors in the anesthesiology department. Do you have doctors there now? Is it all
So we have our chief medical officer, Dr. Gene Gessner. He's actually an anesthesiologist. We do have him, but we staff our surgeries with what's called CRNAs, and that is Certified Registered Nurse Anesthetists. And they are the nurses that are trained specialty in anesthesia to be able to provide those same services as an anesthesiologist, right? Right now we have 3 main full-time CRNAs, and we're hiring for 2 additional.
So there's not gonna be any doctors in anesthesia?
Usually you only have those doctors if, let's say, you're doing a higher level surgery, like a heart transplant. You would have an anesthesiologist in a heart transplant. If we're doing an appendectomy, so an appendix removal, that could be done by a CRNA. Yeah, different things like that. Yeah. All very good questions. Yeah. So orthopedics, yes, we do offer orthopedics. We have Dr. Tedesco. He's our orthopedic surgeon. He does joints, very, very good. He comes out to us through DMOS. Lives here in town, Des Moines Medical Orthopedics. They're in Des Moines, and we've talked with them. We would really like to have a spine and hip doctor by the end of the year, so that's my goal, is to work on that as well. So we can really cover the whole person in terms of broken bones and offer those joint replacement services. There we go. Okay, let's talk about some numbers. So for 24, we had 32 physicians and advanced practice providers. Advanced practice providers, that term means nurse practitioners and PAs. We have a mix, a few, mostly PAs, but 331 team members, 247 births. So our labor and delivery renovation project that we're about to start in March, that's going to be a 2-year-long project. It will be a rolling renovation of the labor and delivery department, and at the end of it, we should be able to handle 100 more deliveries a year, because that number is already growing. 1,989 surgeries, 5,226 patient days, 8,000 ER visits plus, 59,000 clinic visits. So as you can see, we very much are although we're considered a smaller hospital, so by the numbers, we are a 49-bed hospital. Even though we're a 49-bed hospital, the service level that we offer is one, I would say, of easily a 100-bed hospital. We've become very efficient at processing patients through. We have a 6-bed ER. We have a 5-bed ICU. We have 4 beds in the ICU that are called step-down beds. And then we have 22 beds on our med-surg floor, which is your basic general acute care hospital floor. Because of all that, all of those beds then support the different service lines that we have. Yes? Our occupancy rate? So right now, I think we're at 24 in the hospital, 24 patients. Are you asking about our average daily census? Yeah. So when I first came back in June, our average daily census was around 14. And yeah, yeah, some months are busier, some months are leaner. I would say since the start of fourth quarter of last year, we have slowly been increasing. And we averagely run around 19 to 25 on an average inpatient census. When we talk about that we're a 49-bed licensed hospital, we average staffing for 22 beds. So today, with 24 beds being full, we're full. We're very full. But we're also very good at discharging and turning the bed so that we can get other patients through that are in the ER. With only a 6-bed ER, you really have to be, because if not, your ER backs up pretty quick. I would like to see us add 4 more rooms to the ER so that we can have a 10-bed ER. I think that would really help relieve a lot of our pressure. Any other questions about the numbers? Yes.
About staffing the ER with
Yes. So
contract arrangement from outside partners?
yes, it absolutely is. So that's a great question. So staffing, let's talk about the doctors that staff our ER. So we work very closely with a group in Des Moines, and they come out and they are the ER doctors that staff our ER, and they're phenomenal. They really are. They bring a lot of expertise with them. We do employ, most times we employ a lot of the patient techs, the nurses, things like that. We employ those at our own level. We do employ some of the doctors. It's kind of a mix as far as our 32 physicians and providers. Some of them we get through contract with the Des Moines that come through their own group. Some of them are from within UnityPoint. They have an arm of the health system called UPC, UnityPoint Clinic, and that is the doctor arm of UnityPoint Health. And we get quite a few doctors through them. And then we still have some doctors that are just directly contracted with us as the hospital and that we actually employ. It's a mix in between. Good question. Yeah. Any other questions about the numbers of the hospital? Okay, so let's talk about the Center of Excellence grant. Center of Excellence grant for rural maternity health. So just like I said that we are a Center of Excellence for bariatric surgeries, we also have the very big notoriety of being a Center of Excellence for rural maternal health. That is a grant that has been very helpful to us because it's helped us to put money into that labor and delivery renovation. Total overall, that renovation that we've scheduled for the hospital is around, it was about $3.2 million. Just recently, we were getting ready to start it in March, and we set out for final bids, and that project went up to a $4 million project. How are we getting those funds, right? Those are funds that have been raised by the community. Those are funds that have come through grants like this. A number of different grants have compiled together to complete the 3.2. Plus, still, we have some federal funding that we're waiting on and keeping our fingers crossed for. Yes. So, any questions around funding or grants? So we have.
Can I interrupt a minute?
Yes, yes.
The reason we use the mics, or you have to give the question, is for our recording so that people
okay.
can see the recording.
Very good. All right.
So if you would repeat the question.
Yes, so the question was, where does our grant funding come from? So we get grant funding from a number of different places. We apply through federal programs, there's state programs. There's also one of our more recent grants that we received was from the Prairie Meadows Casino Foundation. So Prairie Meadows Casino, a little bit about them. They are, as I understand it, they're a non-for-profit. They're only the second non-for-profit in the nation, and I believe they are responsible for giving back up to 22% of their annual revenue to the community through grants and things like that. In 24, we were a recipient of that. We received $25,000 towards our labor and delivery project. And so with the new increase in costs going from $3.2 million to $4 million in that $800,000 gap, we're going to approach them again. The grant cycle for them ends here at the end of February, and so we're approaching them again to ask for a large chunk of that money. And I want to also give a lot of credit to, I don't know how many people know about our foundation. The hospital has a very strong foundation, and they do an enormous job of really just being that head to raise funds for us. They're very active in the things that they do. We have a lot of really great community members who donate money to the foundation, and then that allows us to make up the financial gaps that we see and things like that. And it's really, as unfortunately as it is, cost goes up, things go up, drywall goes up for construction projects, so it's just part of it. It was a great question, though.
David-Paul, can you talk about the photos that are on this slide?
Yes.
Can you talk about the photos? I think, in particular, the bottom is great, but both.
Yes. So this photo right down here, this is a really awesome photo. All the ladies in this photo are delivering or have delivered. This is Dr. Heidi Klingelhofer. She's one of our primary care physicians. We just so happen to have a point where we had a lot of really pregnant ladies at the hospital. There's Dr. Anna Mensing. She's one of our general surgeons. She's also pregnant. It was a neat photo that we took in regards to an opportunity there. So, yeah. And then over here, we have, let's see, Dr. Ferguson, if I'm seeing that right. Sorry, I'm having a hard time seeing that. Dr. Ferguson in the black scrubs. In the middle, back there in the back, is Dr. Dolby Albright. This is Josie. She's our midwife. She's an RN. over there on the end at the far, it would be your left, is Dr. Tigges. She's our OB-GYN, Dr. Elizabeth Tigges. And then over here is Dr. Flanagan, Dr. Abby Flanagan. She is our FP with OB, which is a family practice doctor that has been trained in obstetrics. She's a big part of delivering our babies. And so we are also looking for an additional family practice doctor that's trained in OB. We find that they really fit in very well in rural markets. But they are like unicorns. They're very hard to find. So, yeah. Any questions around that? Yes. Yeah. Yes.
How does urgent care work as part of the hospital? Because
Yeah.
that's staffed all the time.
Yes, so that's a very good question. So we actually have at the hospital, we have a walk-in clinic. And that walk-in clinic is supposed to be open 6 days a week till 7, except for on Saturdays. I think they're supposed to be open till 2. Lately, we've been struggling with the staffing there. We have one full-time provider. We are looking for a second nurse practitioner to help staff that so that we can complete all those hours that we're supposed to be open. And it's a very big help. We find that some of our ER numbers went down from last year, but we really honestly saw our walk-in clinic numbers. So when, let's say, it's a weekend Friday at 5 o'clock and normally your regular doctor's office is closed, that walk-in clinic is a really great option for that and helps to kind of give those patients an option to still get health care after hours. Yeah. Other questions? That was a good question around that. Did I answer your question, ma'am? Yeah.
Can I ask you another question?
Yeah.
Sorry, over here. To your point about how, it's 5 o'clock, you'd like to see your primary care physician. They're closed. Will your primary care physician be able to see your visit too?
Yes.
I'm
Yeah.
giving you a softball.
Yes, yes. So let's talk about that. All hospitals these days run on computers, right? As everything does. And every hospital has at the core of its heart an electronic medical record system or an electronic healthcare record system. Ours is called Epic, and it's interlinked with everything else within UnityPoint, right? It's interlinked with lab, radiology, and all these other things. So when you come to, let's say your normal doctor is Dr. Heidi Klingelhofer, right? But it's Friday afternoon at 5 o'clock and the normal clinic is closed, so you go down to the walk-in clinic. Maybe you just have a head cold. And so you go there, you see the nurse practitioner that's there, and then on Monday, Dr. Klingelhofer will actually see the report that provider puts in. Right? They'll see your report. If you had any x-rays done, if you had any labs taken, they'll see all that. And it also actually goes to an app that you can sign up for on your phone, which gives you all of the reports and everything as well. Frequently, what I hear from the doctors is that the results come back so quickly to the app in the person's phone that they don't even get a chance to see them before they hit the person's phone. So it's one of those things that is just part of the speed of information these days. Yes?
I just want to make a comment. The Epic system is wonderful.
Mm-hmm.
I use it all the time. It connects with the University of Iowa.
Yes.
I really like it. I applaud that.
Yes.
That improvement.
I would agree with you. I will tell you, in the big world of electronic medical record system, Epic is the number one. They're the best. They're the Mercedes-Benz of EMR systems. They come with a very high dollar price, but that's part of doing business these days in healthcare. We really are grateful. We're so blessed to have that as our EMR because it provides all kinds of access. The ease of information is very quick. So that's about, it doesn't get much better than that. We're blessed to have that for sure. Any other questions around that? Yes. That's a great question.
Hey, David-Paul, before you answer
Yeah.
that one, I think there's some confusion. Can you just real quick go back and say what EPIC is? Sorry if you don't mind.
Yes.
Real quick, because I think
Yeah.
there's confusion as to what that acronym is.
So Epic it's an electronic medical record system, right? EMR, or that's also very synonymous with EHR, which is electronic health record system. Okay? And when you see somebody, when you go, let's say you go to our orthopedics clinic to make an appointment, and the girl behind the counter is sitting there and she's typing away on the computer, she is in Epic. Epic touches everything. It's the scheduling software component. It's the component that the radiologists use to read out of. It's the component that runs our lab results. When they schedule you for physical therapy, all of that is done in Epic. It's one giant ecosystem, one large software computer system. Yes. Tell me your question again. I'm sorry. Yes. So, does Epic have an AI diagnostic component to it? That is a great question. Here's what I'm going to say about it. They do. They do have it, but it's very specific. It is not software wide yet. AI has been used for a lot longer than people realize in radiology. And where it's been used in radiology predominantly is in mammogram detection, right? So let's talk about the doctors that are in radiology. So in the radiology department, when you go and have a chest x-ray or you have a CT or an MRI or any of these other things, ultrasound, in particular a mammogram, the doctor that reads those is called a radiologist. And all he does is sit in a very dark room all day long in front of a computer, and he just reads exam after exam after exam. And mammograms are such high detailed studies that you don't want to miss a possible early detection cancer spot on there. And that's the task that those radiologists have been given. You have to have all kinds of certifications. You have to do so many reads to be qualified to read mammograms. So for a number of years now, I'd say almost 6 years, there have been early detection systems in radiology which assist with that and will tell the doctor these are some possible areas to look at on the exam for a mammogram, and it's extremely helpful. Now that's a limited space where AI is, and I think it works well there. But there's other spaces that AI has started coming into in healthcare, particularly in the area of voice dictation, right? Something like what you're seeing here. So if you're a doctor in the ER or a primary care doctor, whenever you see a patient, you have to give a note. You have to do some documentation and some dictation on it, right? In the old days, it used to be a little microphone, something like this. You would talk into it and say, I saw the patient today. They were 35 years old. They presented with a runny nose, right? And there used to be transcriptionists. And we had a whole department of them, right? And you might have 6 transcriptionists for one hospital, and all they would do is type up all those notes that the doctor read into the microphone. And now, it's all done like this. And that's an area where AI detection is really also filtering into the hospital. So far, that's the area where AI has been welcomed. Other areas for AI to come in, I think it's really been not received as well. You want AI assistance, you don't want AI diagnosis. Does that make sense? You always want the human at the end to make the final decision. And I think in that way AI is useful. I think this is fine. I think this is, it's helpful, and that's great. It is kind of sad because it's one of those things. I remember the hospitals I first started at, I loved the ladies that worked in the transcription department. They were the nicest. Unfortunately, it's one of those things that no longer exists. It's been replaced by this sort of thing. And as I mentioned in mammogram early detection services, those are very helpful. If I were a radiologist, I would welcome that early detection software. So, very good question. Anything else around computer systems or AI in healthcare or anything like that? Yes. Yes. Yes, it is. So the question was, is the AI component part of the Epic system? And yes, it is. However, Epic, like electronic medical records present in 2 different ways. There's those options where you buy it and it's just all one software package and it is what it is. It's kind of like DirecTV, right? You buy it and you get all everything, the whole package. And then there's others like Epic or Cerner, and they're modularized, right? So you can buy the labor and delivery module, but you might not purchase the surgery module because it's very costly. Thankfully, UnityPoint is large enough and strong enough. They bought everything. We have it all. We have every software for it, even the bolt-on and the add-on pieces. So yes, it is part, and it is ingrained in the EMR system in Epic, but it's optional as far as was it purchased. For us, we've purchased all the possible resources. We have the full package. Any other questions? All right. Okay, so let's talk about commitment to the community. Several years, about 3 or 4 years ago, UnityPoint purchased Grinnell Regional Medical Center from Grinnell as a community hospital. I am told that Grinnell used to be so much more participatory in the community. They used to have events and do all these things. And unfortunately, also aside from that, there was also COVID, which really, it saddened my heart because the way that hospitals used to present to communities was more inviting. It was one of come into our doors. Many hospitals had dining areas that people would often come to on Saturdays or Sundays and get lunch. Those were the kinds of hospitals that I was used to before. And then when COVID happened, we told people, don't come in, stay out, and set up all kinds of other regulations. I want to get us back to a point where we really have a very strong presence in the community, where we're participating in events, where you see our name in places and you get to know more about us. So this is just a small bit of some of the things that we do. So we had a 5K, 3K walk run, which was very successful. We had a fantastic turnout for that, if anybody was present in that. Our public health department, they're really great. That's another unique thing about us as a hospital. Many county public health departments are just entities that are part of the county and exist on their own. But here in Poweshiek County, that's actually a department of the hospital. We oversee the public health department. And they've been great. They do a lot of things in the community. In partnership with our OBGYN clinic, opened a village closet for caregivers of babies 0 to 12 months of age. That's a really great program to have here in the community. It services a need, and I think that it's in the public health building. Yes, that's where you would go for that. Current partnership with the Grinnell Area Chamber of Commerce provides connecting for women's sessions in the community. I don't know if anybody ever attends the farmers markets as well. We always try and have an educational booth there, and we try and be very present at that as well. Excuse me. Many departments participate in community events like Jingle Bell Holiday, Trunk or Treat, Easter Egg Hunt, etc. Any questions or suggestions around participation in the community as a hospital? No? Yes. 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 I have learned a lot of history around the gift shop and the auxiliary and everything like that. What I can share with you is that we are working towards starting back up the volunteer program. Now, separate from that, the gift shop is going to be a little bit of a harder one, given the renovations that we have in place lined up. Another renovation, forgive me, I forgot to mention this. Here soon, we are also starting a renovation of our ER and radiology waiting room. Right now, if you've been up to the ER area, those two waiting rooms are the same space. And if you come up at, let's say 10 in the morning, or I'm sorry, 10 in the evening, that's the same space right there. The patients sit in the same area. And right now, when you enter through the ER doors, you still have access to most of the hospital. It's not the greatest model in the world. So we're getting ready to start a renovation project where we're actually going to separate those two areas so they are two separate waiting rooms, and then we'll also have badge entry and access in the evening so that you can't just get throughout the hospital or wander around, which will be a really big improvement in security for us. But because space is a premium in the hospital right now, it's very difficult to find a spot to say, okay, where could we open up a gift shop? It is something that's on the table. It's something we're talking about, something we're thinking about. As I said before, I really want to change the presence of the hospital and how we invite people into our doors. I think that's a big part of that. My wife just had surgery about 2-3 weeks ago, and I was a regular patient family member. My wife was in the surgery department, and we were waiting there in the surgery department waiting room. I was there with my kids, and they were bored out of their mind. In the old days, I would have taken them to the gift shop to go wander around and just pass some time. So I think gift shops are a big part of hospitals, and I don't want to let that go. So hopefully soon, but we'll see.
This is a big one. We used to have the SEED program. Are you familiar with that?
I'm not familiar with that one.
It was a program that was every Monday the hospital put on it, similar to this.
Mm-hmm.
And that we had speakers.
I would love that.
I think that went with COVID
Uh-huh.
and UnityPoint.
Yeah. Yeah, I would absolutely love that. The world with COVID became a different place for a little bit, and I think getting things back to in person, relationships are built face to face, meeting people, talking to them, and I think inviting them into your hospital to have educational sessions on any number of healthcare topics. I'm just giving a general education session on healthcare overall, but maybe presenting a specific topic around women's health or about mammography or about any of these other service lines, I think would be great. We have some doctors that are really, really big and like to share information. I think Dr. Tedesco, our orthopedic surgeon, he's fantastic. He loves to talk with people about, joints and bones and hips and everything. So, I would really like to start that up again. I didn't know about that program. Yeah. Any others? Oh, yes. Oh, one. Sorry.
I'm curious. Some years ago, I benefited and thought very highly. I don't know if it was called a nutrition, but it had to do with diabetic support.
Yes.
Has that gone by the wayside for the time being, or?
So the question there was a diabetic education program, correct? Yes. So we actually have that on our radar. It's something that we thought about at the end of the year, and what we're looking for right now is a diabetic educator. That person typically starts off as a nurse, and so again, we have to tap into the nursing pool, and then they have to be sent away for education and training to specifically become that diabetic educator. So it's something that we're working on. It is on our radar. I don't have a set date for it, but it is a program we would like to see return. Yes.
Do you have a time frame for when the volunteer program might be coming online, and how would you be announcing that?
So I don't. The short answer there. The question was, do we have a time frame for when the volunteer program might become a reality again? Right. I don't have an answer for that, not yet. What I can say is that we are currently having meetings right now in first quarter about establishing that program. What we had to wait on. So, as Grinnell Regional Medical Center and as a UnityPoint Hospital, we have to coordinate really heavily on a lot of services with Des Moines. Des Moines has a volunteer program, and so we're really kind of piggybacking off of their program. Service lines programs have to have policies, they have to have rules and structure to them, and so we're waiting for Des Moines to get to a point where really they could allow us to align with them. That was at the end of last year. We're now at a point where we're starting to have meetings about what this program looks like. I'm hoping that midsummer it could be an official reality, and we could begin to announce it. When we announce it, we'll really want to be vocal in the community about it, because we've had a lot of people come to us and say, I really like the hospital, I want to volunteer here, what can I do to participate in things like that? Yeah, so it is on our radar, and hopefully soon it'll become a reality. Yes?
What is the situation with hospice right now?
Yes, so yes. So the question was, what is the situation with hospice right now in Grinnell connected to UnityPoint? So hospice is actually an entirely separate arm, not underneath the hospital. It's called UnityPoint at Home. That's UnityPoint's hospice arm. And we work very closely with them, but we have very little administrative interaction with them. As far as I know, I think they did go through some struggles at the end of the year as far as staffing, but I think they've overcome those struggles. We are working with them on a program to bring them into the hospital and just have them participate on the med-surg floor and have a greater presence there. So it's something that we're trying to partner with them on. But as far as I know, with the little bit that I know of them, I think they're doing fine now. I think they're stable and they have enough employees in the community.
David-Paul, we have one more question, and then I think we should take a break, if
Okay.
that's okay. We're
Yeah.
at that break time, so one more question.
One more
We'll
question.
take a break.
Promote the new lab.
What's that? I'm sorry? Would I promote the new lab? Yes. Okay, yes. Absolutely. So we just got done with a big lab renovation. It doubled the size of the old lab footprint, and it was a long time coming and very much needed. So the lab is now able to offer more service lines, do more procedures, and at the same time, it presents an entirely new space for patients to come into. And I can't think of how much that project was, because that project was already in place when I came on board, but we're very excited about that, and I think the lab department's really happy about that new space. So,
They should be. It's a gorgeous new space.
it's a beautiful, many of us
Yeah.
stare at that new space and envy it, yeah. If you drive underneath the under part there of the hospital, you can actually see it there on your right as you're passing by, yeah. It's a pretty nice space. I thankfully haven't had to use it yet, but it's a beautiful area.
Awesome. Well, let's take a 10-minute break. We'll get back here at about 55. And I'm going to turn off the subtitles so we don't get all the conversation in the front row. And we'll see you in about 10 minutes. Wonderful. If you could wait until I could get to you with a mic. Because we are recording this so others can listen to this presentation at another time. So if we don't get a mic to you, then it's really hard for people on the recording to hear what the question was, and it gets confusing. So just raise your hand, and I'll run over with a mic. Steve also has a mic, so the two of us will get to you. And if not, we'll just, if we don't get to you right in time, then we're going to ask you to repeat the question back into the mic, even if you've asked the question. So let's use microphones. But David-Paul, thank you. Oh, let's get this back going. Sorry. And we'll turn it back over. Maybe to you. Yep. All right. There you go. And is it doing
All right.
the
Testing?
subtitles? Yep. There we go.
There we go. Okay, can everybody hear me in the back? Wonderful. Okay. So I'm going to touch base real quick on two things that I thought somebody came up and mentioned something to me, and I think it's worth mentioning here. So we have a new doctor coming this year. We have a new family practice physician coming who's going to be joining our team at UnityPoint in Grinnell. His name is Dr. Kyle Grover. He's coming fresh out of residency to us. His residency is ending in late May, and he'll be starting with us in August. So keep your eyes out in the paper and around town in the community, because we're going to really be trying to announce him as we get closer to his official start date. But that's Dr. Kyle Grover. And he will also be rotating down through Montezuma, through our Montezuma clinic. So, yeah. Okay. Oh, it's kind of doing its own thing. Good old AI there. Wow. That's why we don't let it make medical decisions. Okay, well that comes to the end of my slideshow. You guys have really had some fantastic questions. I've loved a lot of the things. The SEED program that was mentioned, I think I might try and see if we can talk with Sarah, and I'd love to have Dr. Tedesco come out and talk about our orthopedic services. I think that would be really nice, and share that information. Hopefully, we could get back up to a time where we have regular SEED meetings. I think that would be great. Yes, sir. Yes. There we go.
And during COVID, we got inoculations at the public health department.
Yes.
Is that service still being offered? I've not been aware of it.
Yes. So the public health. The question was, are the inoculations or vaccines still offered at public health? And yes, they do still offer them. They aren't really very public or vocal about them right now. But as we enter flu season, usually at the start of the fall, you'll really see them trying to promote that. But yes, it is still offered at public health. Yes. Good question. Yes, ma'am.
I'm just curious how you in the hospital arena are handling the federal scare that I
Yeah.
feel with Medicare, Medicaid.
Yes.
It seems like a big deal.
Yes, you're right. It is a very, very big deal. How are we handling it? So, we actually, so the question was, how are we handling basically the changes that are occurring in the federal government and their funding regulations with the new administration? Right? How is healthcare handling that? How are we at Grinnell handling that? So I was asked in a large employee meeting the other day if we were prepared for any sort of disruption in Medicare and Medicaid. And so just a little bit of background education. We have in healthcare what's called a payer mix. And the payer mix refers to, in your area, what are your number one types of insurance, right? So Medicare is almost always the first payer mix in most people's area, whether you live in a city or a rural area, but most rural areas. Then usually it's Medicaid, or if it's a commercial insurance line, it's almost always Blue Cross Blue Shield. They're just the largest commercial insurance carrier. And then all the other commercial insurances. So Medicare is, of course, for seniors. Medicaid is for the underserved. And if there's a disruption in those payments, how is that going to affect healthcare? The answer is badly. Really, really badly. Very badly. What's our answer for that? Well, there isn't really one. Most hospitals, so let's talk about strength and financials. So right now, because we are a corporately owned hospital now, UnityPoint purchased Grinnell Regional Medical Center in full. We are not a rural affiliate. We are actually a corporately owned UnityPoint hospital. But that's kind of a good thing because there's strength in that. UnityPoint is a very, very financially strong health system. That's a big help to us because it means that if for some reason there was a bit of a pinch in the Medicaid payments or Medicare payments coming in, it would be okay. We, as Grinnell Regional Medical Center, made budget for 24. We did great financially. It was a good year for the numbers. Volumes were good. So although in healthcare you can have ups and downs and dips in the month, maybe one month is in the red, the other months are in the black, but you want to mitigate that as much as possible. Typically, February is honestly always a month of struggle because you have shorter days to make the same amount of finances. So it doesn't matter whether you own a pizza shop or a hospital, you have the less days to make the same number of payments. And honestly, we've been so busy with volume that February is going to be a good month for us as well. So those are all really good and positive things. But if for some reason Medicare was disrupted, Medicaid not so much. Medicaid is almost always the smallest payment in healthcare. That's Medicaid, right? So Medicaid only pays about $20 on every 100. So when we have at a state level, at a federal level, at any sort of political level, when we have arguments around Medicaid, we're fighting over the smallest payment in the industry, right? And then Medicare is usually the best payment in the industry, right? But it's never 100%, right? And then the commercial insurances fall in the spectrum somewhere in between. And just a little bit of education on that, you have what's called contractual service agreements. So let's talk about that. So what that means is if you have Blue Cross Blue Shield as a commercial insurance, maybe through a job or whatever, you work for a company and they give you Blue Cross Blue Shield. It's really great for the person who is the card holder. Pardon me. It's really great. You can get in almost anywhere. It's very well accepted. But from the hospital or from the payer end, it's not the best. Because they're so strong, they have the ability to then negotiate prices. So if you said, I had surgery last week and I had my appendix out and I have Blue Cross Blue Shield insurance and we as a hospital file that bill with Blue Cross Blue Shield, depending on what that service cost, there's what's called contractual agreements, which means that Blue Cross Blue Shield is going to tell us, well, that surgery was $35,000, but we're only contractually obligated to you for 35%. So that's what we're going to give you as your payment is 35% of your charges. That's a big gap. That's a big gap. That's why it is so important. Numbers in volume numbers, patients mean everything in healthcare. Healthcare has become an incredibly competitive industry and people have choices. People don't have to use your services. They can go to other doctors' offices, other hospitals, other walk-in clinics, other ERs. So it's so important to deliver a good service these days. Healthcare has really changed from being patient-centered to customer service-centered, right? We really need to offer a good experience to you as the patient, to your family members, to make sure that they're treated well. We have to offer the right services to you so that you choose us and that you come to our doors. Because every little bit matters. So you have to see enough people to cover all those losses. There's always, in any business, there is almost always what you call a loss leader, right? A loss leader is the service or product that you offer and it loses the most money. But it's made up for by service lines or products that you offer that pay the bills. For us, it's bariatric services, our general surgery bariatric services department. Those services that we offer are one of the core lines that holds up the hospital financially. And it allows us to offer other things that don't make as much money. Then the next one would be obstetrics, OB, baby deliveries, and those have just blown through the roof, so those are really great. As I said, I'd like to see us expand orthopedics this year. We've also been asked by the community and by our doctors and other providers to consider getting cardiology here. We have a cardiology clinic, but actually doing cardiology services here at the hospital. That's a very, very large lift because cardiologists are super expensive, but beyond that, the equipment, and you almost have to build an entirely new surgery space, especially for cardiology procedures. And that is an enormous lift. When we look at at the hospital, when we say, okay, what comes after the labor and delivery project? That's a 2-year-long project. Very much needed, great thing. But what are we going to do after that? So 2 areas we want to focus on, OR, surgery department, and our med-surg floor. Those are 2 different experiences, and in one, if what we're wanting to do is add 2 more surgery rooms, surgery department rooms, to expand our surgery department. That's a great place to spend the money because when you can do more surgeries, that instantly hits your books, and it's just good business, right? You're instantly going to see that return on the money. On the med-surg floor, we have smaller rooms, and out of the 22 rooms we have there, 5 of them are double rooms. That's an older model. Most places you go these days, your rooms are larger and they're single rooms. So that's the area where the warm fuzzy is given. That's the area where the patient and their family get to experience our services, right? When you're in surgery, you're asleep, so you don't care that we added 2 more surgery rooms. But both those amounts are needed. Both those investments are needed. We really do need to renovate our med-surg floor so that we can offer a better, more open line of service, more quality experience for our patients, for their families. I'd like to see the size of the room double. Right now we have some rooms where the bathroom services are shared between the 2 patients. That's an older model. Most places these days offer a single room with individual bathroom services. So little things like that, you wouldn't believe how much they matter, and they matter to us. So that's probably the next big thing that we'll do a funding push for. Questions around any of that? Yes.
How many robots do the surgical people use?
That's a great question. Yes. So we have 1 surgical Da Vinci robot at the hospital right now. It's really a neat thing. If you ever have a chance to look it up or see it, it's a really neat thing to see in action. We have been asked by the general surgeons for a 2nd Da Vinci robot. That's a big cost. So you gotta love technology. Most of us have a cell phone, right? And every several years they come out with a new cell phone model. And then the companies want you to buy the new model because the old model is old. And so it's very similar to that. So right now they've come out with a new Da Vinci model. That new robot is $2.5 million. The model that we currently have is still a very good model. When I was talking to the rep who sells Da Vinci robots, I said, so what are the benefits to the new model? Is it a smaller footprint? Is it shorter? Is it better software? Is it faster? And they said, no, there's none of that. And I said, okay, so what's the difference? I said, surely there's something. They said, no, we just kind of refreshed everything. I said, okay. Can I still buy the old model? And they said, yeah, the old model is $1.9 million, so just under 2. So still a big investment. Now, why would we want to do that? Well, we have 3 general surgeons. 2 of our general surgeons do bariatric surgeries, and the 3rd one, Dr. Mensing, she's our newest one. You might have seen her up there in the picture, pregnant. So So almost all of the residents coming out of the university right now for general surgery are trained on robotics. The university as a health system has way deeper pockets than community hospitals. So they buy the best technology and they train their residents on that. So when these younger, to me, they're kids, come out of residency as general surgeons, they want to work on a robot. They're actually moving away from just standard open general surgery because they're so used to robotics. And how does robotics help? What's an area? So we use it on everything from difficult gallbladder removals to definitely to our bariatric surgeries. It's a really interesting thing to see in action. The patient's here on the table, and when they start the robot, it actually moves in across the room, comes down, and it has about 5 arms, and it'll pick up all of the laparoscopic instruments. The doctor is over in a little, I'll call it a cockpit over in the corner of the room, and he lays his head down so that he can see a screen, and he has little joysticks, and he controls everything. The newer robots offer greater sensitivity and touch and responsiveness to the doctor's movements, so maybe that's a positive. I don't know if it's $600,000 worth of positive, but and that is even something that we'll have to overcome. We'll have to find a way around it. What I can tell you is, as far as equipment purchases, something else. This year we're spending a lot of investment capital on getting new equipment around the hospital. And then next year, the big event, the big purchase that we have slated for next year is we're going to buy a new MRI machine. That new MRI machine is going to be $1.4 million. And that's after a lot of haggling and talking them down. Hopefully not. Hopefully, we're going to think positive. We're going to think positive. But these are the things that we have to have in healthcare. Our MRI machine is extremely old. It's way past its end of life stage, and so it is very out of date. It's still usable, but it breaks down frequently, and we get it fixed frequently. Just like your car, it will only last so long. And so the new MRI machine is already slated. We've signed paperwork on it, and it's going to be very welcome to get in. Everybody likes the brand new, fancy, shiny things. So, yes, another question.
Could you talk about visiting specialists who come to the hospital? Which specialties are now coming, and do you hope to arrange more?
Yes, we do. So we have a range of visiting specialists. So we have a cardiology group that comes out. Hopefully everybody was able to hear the clinic. Just a question around visiting specialists and who comes and what service line. So right now, cardiology is a line where we receive both UnityPoint cardiologists and we receive also Iowa Heart cardiologists. We also have a urologist, which is a visiting specialist out of Pella, Dr. Banstra. And so as some of these visiting specialists age out or they decide to start cutting back on their services, I would really like to take the step forward and hire our own urologist so that it's not a visiting specialist, but that we actually have the doctor here locally in the community and they're part of our regular medical staff. That's something that our medical staff has asked me for, is when the visiting specialist cuts back or scales back on their services, to replace them with a permanent doctor here. So we offer other services than that. We have, of course, our ENT, but he's local. I'm trying to think of other visiting specialists. I'm drawing a short on others at the moment, but I know that we have quite a few in there. Yeah. Yes, sir.
What you're talking about takes a lot of power.
Yes.
What arrangements are there for power outages?
So we have our own. Most hospitals, their power reserves are usually generators, right? And we have our own power reserves and our own generators. Most hospitals have a entirely in-ground set of diesel fuel to power. Through certain requirements and regulations, we have to be able to run the hospital for so many days without power. And I want to say it's something like 7 days, but I think we can actually run ours for around 15 days with no power. Yeah. Now, that doesn't mean that all services get power, right? We're talking about certain things. And we actually, a lot of people don't know how much work goes into making everything happen, but when we have a power outage, the timing for us is 5 seconds or less before everything kicks back on. If you are in a patient room and you see if you see an outlet that has a red plate, a plug-in outlet, those are special that will always have power to them and never lose power, right? The ones that are just white and standard, those might lose power for a little bit, but it'll kick back on as soon as the generator rolls over. But the red power outlet ones are secure and they just always have power. So, yes.
Curious whether you have behavioral health services at the hospital?
So we have telehealth, mental health services, and when I say mental health, it's really just telehealth med management services. That was something that was asked for. So med management means if it's different from counseling, right? I think when we talk about behavioral health or mental health, a lot of people think about counseling. Unfortunately, we're not at a point where we have that yet. We've talked about adding it on as a service. What I'm told, this decision was made before I came on board, but what I'm told is that Grinnell as a community has a lot of therapists in it already. And so it's different levels of responsibility and degrees, right? So what's called a LSCSW, which is a licensed clinical social worker, is normally the person that you would see for counseling or therapy services. But for med management services, let's say if you were going to get on a particular medication because maybe you were suffering from depression, that would be done by a psychiatrist. And so we actually have contracted with a company and we provide those services via telehealth for med management, right? If maybe you were on an antidepressant and you wanted to talk with somebody about changing to a different one because that one was making you nauseous, right? Those sort of things. But therapy services, the same med management patients have come to us and have liked the experience, and they've said, you know, would you ever consider expanding it to offer therapy? And we would. And I would like to have those in-house. I think telehealth services are good, but I don't think they replace the experience of connecting with the actual doctor. Yeah. Yeah. I think they have their place, but I don't like them as permanent replacements, right? I like them as a Band-Aid, but not as a permanent long-term solution.
Along the same vein of that question, can you also talk about the space in the emergency room?
Yes.
That is a safe space?
Yeah, so so as I said before, we have 6 rooms in our emergency room. It's a very nice emergency room. One of the rooms in particular is actually set up for mental health services patients. We are even making improvements to that room right now. We have, if you've ever been to our ER, we have sliding glass doors. That area specifically, we're going to reinforce it with stronger sliding glass doors, what they call, there's a certain name for them, a level of qualification. It's basically almost bulletproof, right? It's laminated glass with laminate on both sides, but at the same time, it's also I want to call it plexiglass, but that's not the right word. There's a certain toughness level rating to it. And we're reinforcing those glass doors in those rooms. Yeah, so we're always looking at things that we can do to improve the safety that we offer in terms of our patients, but then also to our employees, to our doctors, to our security guards, things like that. Believe it or not, that in healthcare, it is very sad to say, but we are seeing more and more aggressive patients. Yeah. Yes.
So who serves those patients in that safe space you say you have?
Yeah.
Who serves them?
We do. In what capacity? So normally when let's say a person's having an emotional breakdown, right? They would come to our ER, and medically, often before they can go or get a placement at a mental health facility for a long-term stay, they have to be cleared medically. So they come to us, and our ER doctor will clear them, make sure that, and any number of things. Sometimes somebody could be affected by a change in their chemicals, maybe through a bladder infection or something like that, that would change their mental status. And so while they might be having a change in mental status, the primary issue would be their medical issue. And so that's what we care for and treat first. And then if it's found that there's other issues going on, maybe with substance abuse or substance disorder, that would be where we would involve a mental health hospital. Usually Des Moines. Yeah. Yes.
In case of mass emergency, a huge accident on Interstate 80 or a fire or some serious episode at a school,
Mhm.
what kind of preparation is there to handle such a mass emergency could erupt?
Yes. Fantastic question. So that question was around how I mentioned how well are our services prepared to handle a mass emergency services, right? We frequently refer to that as a mass casualty. A mass casualty. That's what we usually refer to that as. So one of the good things that has come from the mass casualties that you've seen on the news across the years, over the last 20 years, every time you see something on the news in another town, another community, what happens is the government then jumps into action and puts a new regulation in place for us to follow in healthcare. Some of them are good, some of them are bad. All hospitals have to follow them. It doesn't matter what bed size they are, 200 bed or 50 bed, right? And we are equally responsible for those rules. So we have an emergency services coordinator, an emergency preparedness coordinator, and they coordinate. They're our point person in the hospital, and then within UnityPoint, they coordinate regionally to a larger network of people. So then there's somebody who oversees us and Marshalltown for emergency services, because those are both UnityPoint hospitals, and then there's a third hospital that's in our coordination region. So let's talk about like a tornado, right? Let's say a tornado comes through and it tears through a third of Grinnell, right? We have policies, procedures set up in place that would activate the emergency preparedness coordinator. We have things that we practice actually quarterly. We have internal hospital meetings to go through preparations and drills and things like that to be prepared for something like that if we ever saw a mass casualty situation like that. And technically, the rule is a mass casualty situation is anything that actually stresses your services. So if we get fuller than full, if we get more patients than we can handle, if we're overwhelmed by that, that's also technically kicks into service our mass casualty services, our emergency preparedness coordinator. Now there's different levels to it, right? When the temperatures get negative, we also have procedures in preparation for that as well. And it'll kick in a certain level of our emergency preparedness. And we're also affected by so many things on the outside that you might not ever even realize affect us. Does anybody recall back in the fall, it was earlier fall maybe, there was a hurricane that came up through the southern part of the United States. I can't remember the name of it. Helene, yes, thank you. Hurricane comes up, and then it went up the coast of the United States, and it affected states it doesn't normally affect. West Virginia, South Carolina, states like that. There was a lot of flooding in those areas, if you recall. Why would that ever affect Grinnell? Well, the company called B&D, which supplies us with medical saline bags and things like that, it actually caused a national shortage on saline. Because they're such a strong company, they supply almost a third of the United States with its saline. And you would never think or realize that we could be affected by something like that. But when the roads through floods get washed out and the workers can't get to the factory where they make the pharmaceutical goods like bags of saline and stuff like that, the entire healthcare industry goes into a lockdown. And what happens is now it's whoever can build the quickest relationship fastest. And so other companies in the United States like Medline. Medline is headquartered in Chicago, right? You pick up the phone, you instantly call them, and you say, hey, I need to make sure my shipments of saline don't stop. So within UnityPoint, we had a procedure process. We still have weekly calls, and we were at the closest we ever got to having to regulate our saline was an orange level. There was a red, orange, yellow. We existed for a long time in yellow level. And we talk with the doctors. We tell them how much saline they can use, which we never got to a point here in Grinnell. Des Moines did, but we did not, where they had to pick and choose, where the doctors had to say, this is a surgery that needs it. This one, because it's elective, we'll put this one off for now. Right now we're in the green, which is great. But, and again, that's part of being part of UnityPoint. If we had to face that outage on our own, our pockets would not be deep enough to get the attention of the contracts that you need to get the attention of. UnityPoint, thankfully, is strong enough, and they made 2 additional contracts for saline that stepped right in and kept us from getting too bad. Yes.
I have a question about the visiting specialists. I've had occasion to use some of the visiting specialists, and I've been very impressed by their availability and quality. But there are other important areas that are not covered by visiting specialists, like nephrology and diabetes. I wonder if it's mainly a question of availability, or if there are other reasons why you don't cover these other specialties.
That's a wonderful question. So hopefully everybody heard the question. It was around visiting specialist and why don't we offer some other visiting specialist service lines. And you're absolutely right, sir. It is truly around availability. But it's not availability on, hey, can you be here Tuesdays at 3 o'clock? It's availability around the shortage of general doctors in healthcare. It's no different than kind of some of the numbers that I threw out earlier for obstetrics, with there only being 6 residents released every year. It's very similar in the other specialties, whether it's cardiology or internal medicine or endocrinology. So right now, for 25, we're currently looking at a pulmonology clinic. We're working with Iowa Pulmonology to establish that pulmonology clinic. That's something that we're going to bring here soon. We're also currently talking to a rheumatologist. That clinic perhaps wouldn't start until 26, though, early part of 26, to have rheumatology here. And we're hoping and really keeping our fingers crossed, but I don't know that this one will fully go through, to work with an endocrinologist as well. Each of those service lines, you have to, depending on the doctor, you have to get them here. You have to get them credentialed within the state. You have to go through contract negotiations. And some of those service lines, when you think about it, you reach out to other areas. Let's take something like endocrinology. It would be great to have endocrinology here for our residents, for our community members, and for our patients. But are there enough people in Grinnell to support a full-time endocrinologist? The answer is no. Grinnell, by Google, if you ask it, is, I think, 10,000 residents, right? Marshalltown is 30,000 residents. We work so close with Marshalltown. We have a few different outreach clinics up there. They ship into us. They're a smaller hospital than us. And so they're one of the first places that I call to say, hey, would you be interested in sharing an endocrinologist with me? Could we have an outreach clinic up there to help support that, right? And then I start with the surrounding hospitals to see if they would be interested, because we really have to have that regional presence and a stronger drawing to support these specialty doctors, right? Doctors are very expensive. Probably the number one most expensive thing in healthcare is the payroll. It just is, because costs of goods have gone up, so you have to increase your salaries and your wages that you pay your employees. And that's not necessarily a bad thing, but it does just make payroll the most expensive and heaviest part of healthcare. So you have to be creative sometimes on where you send that person, where you draw your patients from, to help support the cost of having our own specialty doctors like that. But there's a shortage overall. It's a good question.
Well, I think that we are up on our time. Time flies when you're having fun. Will you please help me thank David-Paul for being here? It was incredible to have you here. I hope we can have you back, because I know a lot about what's going on, and I'm wondering if it felt kind of like drinking from a fire hose for some today.
Yeah.
So could you, I personally want to offer, you see me every week, so if you have questions or you want to be in contact, please let me know as a trustee of the board. I'm happy to get your questions to David-Paul or put you in contact with David-Paul or others at the hospital. But also, do you want to suggest website? Would that probably be a good place to kind of look at these services again?
Absolutely. Definitely go to our website. And also, I really encourage everybody in here. I thank you for your questions. I really do love talking about healthcare and educating people on how the industry works, how your hospital works. But if there's things that you would like to see at our hospital that we don't currently offer, and I did make notes about the volunteer services and the diabetic services and other things that we'd like to see, please don't hesitate to get a hold of me. You can always call the hospital. They know where I'm at. Or reach out to Sarah, and she can reach out to me as well. Thank you again for all of your questions. I really do appreciate them.
Thank you. So next week, we have Professor Roper, who will be here and talking about Build a Better Grinnell. It has been an ongoing project about planning for the next, I should know, 20? 30, thank you, 30, I was close, not really, 30 years for the community of Grinnell. He's going to take us from the very start to where we're at now and explaining the data, explaining when we got to the 7 priorities that we have for these next 30 years. So I think it'll be a really great presentation, and please bring your questions like you always do, and have a wonderful week. I look forward to seeing you next. I'm going to try. Do you like it? For the most part. You like it, okay. I'm going to try. I now know where the little button is within PowerPoint. So, yes, I will push it. All right. Thank you. Take care, everyone.